Welcome to the October edition of Merit Education Rounds. Today I'll be your host and also will moderate the discussion later, so we normally save the Q&A till the end. I'm Sandra Montero. I'm one of the full-time education scientists at Merit and also the Director of Scholarship at the Center for Simulation-Based Learning. If you are new to Merit, we are a community of scientists, educators, and innovators who often collaborate. We learn often by collaborating to create new knowledge and improve health professions education and patient care. You can learn more about our community at merit.mcmaster.ca, including upcoming, often free events such as journal clubs, future rounds, and specialty topic groups. I'll take a moment to highlight for one moment a group called Insight U. We gather about 4 or 5 times a year to focus on simulation-based education topics. And later this month, Dr. Catherine Tong will lead a discussion on how we can best use simulation to improve our equity, diversity, and inclusivity in our curriculum. I've just posted the link to register to join that discussion in the chat window, and you can find the date for that event on our website when you go to merit.mcmaster.ca. It is an online event, certainly. As already noted, today's event is recorded. We do archive our education rounds, so you can find past events on our website, and today's recording will be available after some post-production editing. So thank you for choosing to spend an hour of your evening with us. I imagine many of you are joining from your home. I encourage you all to take a moment and reflect on the meaning of that. Living and working on a land that we can help take responsibility for. Acknowledging land and territory shows recognition and respect for Aboriginal peoples. It is recognition of their presence both in the past and the present, thinking about what happened in the past and what changes can be made going forward in order to further the reconciliation process. Land acknowledgements mark a small and important step in this process and towards building a positive relationship with Indigenous peoples. For thousands of years, the Indigenous peoples have inhabited and cared for these lands, which is available to us because of treaties that forever changed their experiences and reality. And to the Indigenous caretakers of this land, I offer respect, gratitude, and commit to work towards equity, transparency, and truth in all that I do. Where I live and work is the region of Peel, part of the treaty lands and territory of the Mississaugas of the Credit. I acknowledge the territory of the Anishinaabe, Huron-Wendat, Haudenosaunee, and Ojibwe Chippewa peoples. The land that is home to the Métis and most recently the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. The land that McMaster University campus resides on is protected by the Dish with One Spoon Wampum Agreement and is the traditional territory of the Haudenosaunee and Anishinaabe peoples. Sorry about that. Moving into the scheduled event for today. Dr. Renate Kahlke, who's being showcased at today's event, is a friend, brilliant scientist, and is new to Merit as assistant professor in the Department of Medicine. I consider us all very lucky to get to work with her. She previously contributed to the development of research at the Royal College, and before that held a postdoctoral appointment at the Center for Health Education Scholarship at the University of British Columbia. The foundation of Renate's work is to apply a variety of theoretical lenses to understand alternative approaches to problems in medical education, including sociocultural theory. For example, an alternative way to look at issues of non-compliance with required behaviors, like hand washing, is to understand the value judgments being made. It's not always about the facts. And with that, I will welcome Dr. Kahlke to the stage and to present her perspective today. Thank you.
Thanks so much, Sandra. Am I unmuted? Good. Great.
Sorry, I was muted. I can hear you.
Yeah, you nodded. I saw it. I'll just share my screen. think.
I'll just point out to everyone that if they have questions, you can post them in the chat. I'll monitor them and bring them up when we get to the end.
I'm also quite happy to be interrupted if Sandra could help me moderate that, because I don't think I'll be able to pay attention to both at the same time. But usually kind of goes the usual way where we talk for 30 minutes and then ask questions at the end, but happy to be interrupted if you have questions on the way. So I want to say thanks so much for having me here. I've had a really warm welcome to Merit, and I'm quite grateful to be here. And I'm excited today to present some of my work to you and give you a bit more on my background than what Sandra's already provided. My presentation today is called When It's Hard to Do What's Right, Mapping Influences of Sociocultural Factors on Decision-Making in Clinical Context. But before I jump into that, I wanted to do a little bit more work to introduce myself. As you know, I'm relatively new to Merit. I'm pretty excited to be here. I'm also a little bit nervous. I was telling Sandra that it feels a little bit like my debutante ball tonight, where I'm meeting many of you for the first time in this sort of like weird Zoom world. In terms of background, I hold a PhD in education, and as Sandra mentioned, I use a lot of sociocultural theory in my work, but also I'm a bit promiscuous, I guess, with different theoretical approaches that I use. I'm also, you might not know, an ex-instructional designer. So I worked for a long time, well, not a long time, years, at the University of Alberta, designing curriculum for interprofessional education and simulation, and also teaching instructional design at the graduate level. So that kind of informs my perspective as well. On a personal level, I'm most happy hanging out with my 2-year-old, eating vegan food and riding a bike, as well as talking about sociocultural theory. So this picture I put up is from Copenhagen when Amy, our big European conference, was in Helsinki a few years ago. So that was kind of the confluence of many things that I love. I thought maybe it was appropriate here. So in terms of what I'm hoping to do today, leave a lot of time for discussion, but also give you a little bit of background on my research interests, and describe how sociocultural perspectives can help to frame these problems, and maybe explain to you potentially for the first time what a sociocultural perspective is and what it looks like. And then I'm going to try to ground that sort of broader theoretical discussion in some of my actual research in health advocacy. I'm not going to go into depth on any one study. Rather, I'm sort of offering a series of examples to help illuminate some of the other concepts. I probably should have, but I didn't. I think a quote like this comes across in nearly every study I've ever been involved in. It's not always so succinct or concise, but there's always a moment in which people seem a little bit disappointed in their own behaviors or actions. And this learner in particular had the sense of being disappointed in themselves, but also without a sense of what went wrong or why they didn't do that thing or what they would do differently next time. So sort of this vague sense that I wish things had gone differently, but it didn't. Okay, moving on. And I see these examples in my own life as well. I always have the intention to read more academic papers than I do, or to exercise more. And I sort of hand wave around those things and say, oh, that's really complicated. I kind of know what the reasons are, but I never put it together or make a plan to change. An example that I often use from the clinical context is around antibiotic overprescribing. Everyone seems to believe that overprescribing antibiotics is a problem, but there's evidence that physicians are still often overprescribing or prescribing in moments where they shouldn't or didn't have to. And then despite significant research and education in this area, I feel like we still don't have a clear picture on why this happens or how to influence physicians in a more holistic way to prescribe less. And I think the reason that is because in all of these examples, there's not really one cause. You can't change one thing and have the behavior change. It's complex and embedded in its sociocultural context. And this kind of complexity is what I'm most interested in. In my education background, and I think in medical education too, there's a lot of emphasis on helping people learn what they need to know. So imparting really important content knowledge. And I'm glad that there are people that are trying to teach that. But for me, the moments that I'm interested in are the moments when we know that what the problem is, and we might even know what we should do about it. But for some reason, we don't really understand. We don't act on what we know. So that seemed to me to be an important piece of the education puzzle that was missing. There are a lot of different theories and many different perspectives that try to understand the problem, coming from implementation science, coming from cognitive psych. My research program looks at these moments in clinical education and practice, and I apply sociocultural perspective to understand these problems in a new way and try to unravel them without losing that complexity. So that's sort of a broad overview of my research interests. From there, I'm hoping to kind of give you a bit of information on what a sociocultural perspective is and how it helps me to frame those problems. So sociocultural theory is not one theory. It is a whole web of different theories that have some common assumptions. And I tried to condense all of these theories into just a few slides to give you a sense of kind of what's going on behind them. So some of the assumptions that sociocultural theory makes are that learning occurs in social context. So it's not necessarily what happens in the individual brain, that's how people process interactions that happen between individuals. That's how we learn and grow as human beings. Learning can be formal. So for example, like curriculum or an intentional lecture, but it can also be informal. And in sociocultural analyses, we're particularly interested in those less formal aspects of learning. So where people learn the social norms of the context, or where they learn how to interact with each other. In other words, in a sociocultural analysis, becoming a doctor means learning informal knowledge, of course, but it also, from our perspective, means learning to interact like a doctor, feeling like a doctor, and importantly, being seen by others as a doctor. And in order to make these assumptions a bit more concrete, I spent a lot of time trying to figure out how to tell you what sociocultural theorists might actually do. Like, what do we do when we have a data set that makes this a sociocultural analysis? One of the things that we try to do that's common is try to map a social context. Mapping means looking for practices. So how people interact, their hierarchies, their rituals, their languages, the language that they use. And that's not necessarily observational, like the way that sounds, it makes it seem like we're watching them to see what they do as ethnographers would. And sociocultural theory can be used in ethnography, but it's not always about observation. It can also be about talking to people to understand how they interpret their rituals or how they think about their work. One thing we might look at as an example is rounds presentations. So for example, these involve specific language, ways of interacting with each other, ways of presenting oneself, and ways of asking questions. So Sandra did her land acknowledgement. She gave a little thing about other stuff that was going on in Merit, and then introduces me, and then I also introduce myself. And this is kind of a common way that we understand this will happen, and we orient ourselves accordingly. I also look for and map more socio-material tools. And sociocultural theory uses this term tools, but it doesn't really mean tools like a hammer. It means a set of like more or less concrete things that exist in the environment. So it can be really concrete things like iPhones. iPhones are only going to be a certain size ever, or the hospital layout. You're not going to move corridors overnight, or forms, which kind of need to go back into the computer to be processed and changed. It can also mean material in a different sense. So these are policies or more concrete things that influence action. So as opposed to a conversation, which can change really quickly, a policy or a tool changes more slowly over time. And the important thing about tools, I think, too, is that people can interact with them differently. So we don't always fill out a form in the same way or use the same corridors. We might use shortcuts. So while tools have a concrete presence, people can use them differently. An example that I really like to use when starting in a position in a new department, as I have, historically, the coffee has been a really important technology that we use. So there's this physical coffee that we can go and have together, but there's also the process of going out for a coffee and sitting down at a table and interacting with each other over coffee that tells us how we're going to constrain this meeting, like what kind of conversation it will be. and how we're going to interact with each other. Whereas if we chose to have a meeting in a boardroom, we might sit across from each other and have a very different conversation because of the signals taking place, regardless of whether or not we had an actual coffee. And then really interestingly, when that hiring process happens in a pandemic, it looks, again, really different. So this new technology, Zoom, supplants the old technology of the coffee. And we really have to figure out what we think is important about those old interactions and do our best to try to import them or create new kinds of conversations to have via Zoom or the technologies that are available to us. Practices and socio-material tools are available differently to different people in context. So we don't always all use Zoom in the same way. My interaction with Zoom today is going to be very different than yours. I had to try to load my presentation and was nervous about like whether it would load okay and whether you'd see my slides or whatever. And Sam in the background is like setting me up, making sure the Zoom call is set up, and probably also helping to monitor the chat. So we're all doing different things in this setting, and we all have different power over it. Like I have the power to show my screen and people observing it don't. And the same is true of clinical context. So doctors would access language or charts differently than med students or nurses. They say different kinds of things, they write in different spaces, and they have different kinds of power. The last thing I wanted to mention about that, about the assumptions, is that practices and social material tools are historically constructed. So we didn't just make up today that this is how we were going to interact on Zoom. This is something that's evolved over time. And that makes it relatively permanent. It makes it harder to change. A practice that we make up today is pretty mobile, but historically constituted practices are not. So mapping interactions, so doing this process of mapping between people and between people in their contexts helps me appreciate how the context functions. So what's important, what's not, what's contested, and what's taken for granted. I thought this little map of the Tokyo subway was representative of that for me. It shows interconnections, so how different points relate to each other, and it also shows points of influence. So what the most significant parts of that network are from this particular perspective. And on that note, from this particular perspective, it shows a way of seeing the world that is not the only way of seeing the world. So this is a subway map. It calls your attention to different things than a road map would. And I think in the same way, sociocultural analyses will call your attention to different things than a psychologist would call your attention to, or that you would call your attention to when you were practicing in that setting. And I think that's the power of a sociocultural analysis, is that it can ask you to look a little bit differently at things that you functionally and normally look at in one way. The second sort of philosophy or practice in terms of how I actually do sociocultural research is I look for contradictions within and between social contexts. I think for me, this is one of the most complex principles in sociocultural theory, but I hope you'll bear with me because I think it's one of the most interesting, and maybe at the end you can tell me if it's actually as complicated as I think it is, or if it came out quite simple. So social contexts are not stable or predetermined, they're dynamic. So they change over time. The kinds of things that we value now are not the things that we've always valued. They also interact with each other, and that's what this diagram is representing. So when I come into the Zoom presentation, I'm literally not leaving my family behind me. My kid is still in this house. But even if I went into a different space, all of those values and priorities don't just get left at the door. They come into that next space with you. And the same is true of our learners. When you leave the lecture hall, you don't leave those information and values behind. We assume and hope you bring them into the intensive care unit. And I think that is the really helpful and hopeful thing, because change over time and boundaries between contexts produce contradictions, and old meanings and practices can be replaced with new ones, either as change over time occurs or as people cross boundaries. So when I generate or analyze data, I look for contradictions. Sometimes these are moments when interviewees can't quite reconcile something, so they're silent or discomforted or frustrated with the interview, or when people fundamentally disagree with each other. So you might expect two participants to agree on something, but they don't. Or also, surprisingly frequently, you'll see contradictions within an interview. Someone says one thing and then another thing later on. And that doesn't mean that they're contradictory people, but it flags for me that things that are taken for granted might be more complex than they seem. And it says, hey, this is an interesting thing that as a researcher you ought to be looking at. So as an example, my research on health advocacy looked at how learners come to understand their health advocate role. And when they talked to us about it, they defined health advocacy as both an intrinsic part of their job. Health advocacy is part of what we do, and also as going above and beyond, above and beyond what the normal scope of their work would be. And I think most often, one student or one learner would articulate both perspectives in one interview. And if you ask them about it, they can't quite figure out how they fit together. So that's like, for me, an interesting thing that took a long time to untangle. But it seems to me, from a sociocultural perspective, there's a clash of two different sources of doctor identity. One is doctor as biomedical fixer person, which is a term I coined specifically for this presentation. And the second is doctor as carer advocate. And these two identities represent different contexts influencing what it means to be a doctor and fluctuations in what a doctor has meant over time. They also represent different broader social values that our broader society is telling us doctors are meant to do or be. And importantly, these different identities suggest that different types of work are possible. So if you think of advocacy as your job, then it's something that you fit into your regular job time. If it's something that's going above and beyond, then it's something that's extra and might take place outside of work hours or in what time you feel you have to spare. And obviously that has implications for how we care for patients. This is the third thing that I try to do when I do sociocultural research. And I think it stems from the second, about looking for contradictions. Because for me, these are the moments when deep learning and change can occur, when there's a contradiction. So psychology tends to focus on the role of the individual, and systems research tends to focus on social systems. I think sociocultural perspectives and other perspectives like them are unique because they try to focus on both individuals and the systems in which they participate. So as a result, I try to think about both individual agency, or the power that individuals have to actualize the things that they want to do and their beliefs, and the structure, which are the things in the environment that limit that agency. And I try to think about them at the same time. So on the one hand, systems are relatively stable and individuals don't have a lot of power to change them. So I could, in this presentation, choose to not use PowerPoint, has some precedent, it's a relatively minor change to the way we interact. But I can't really choose to eat spaghetti for an hour on camera instead of doing a talk. It would make everyone really uncomfortable and it wouldn't make sense. So that's kind of what flags to you what an interaction would be. But if I were in an Italian restaurant and started giving you this talk, it wouldn't make a lot of sense and you would be uncomfortable and we wouldn't know how to make sense of it. On the other hand, when there are competing practices available in an environment, we can choose to promote one meaning over another. So when there's a contradiction, like the one around health advocacy, we can choose to promote doctor as carer and advocate over doctor as biomedical technician. And in this presentation, I can draw on my background in adult education to structure my presentation as an opportunity to have a conversation and share knowledge as a community, or I can try to impart my knowledge on you. Or we can choose together to do something in between those two things. And I think importantly, I can't make those decisions independently. I have a lot of power in choosing what to present, more power than you, and how to present it. But you get to choose how you'll interact with it. You can choose to not ask any questions at the end. You can choose to take in a passive mode of engaging with the presentation, or you can ask questions, or you can interrupt. Those are all options available to you. Especially when a shift like the pandemic takes many of our processes online, each of us must decide what we think is important and negotiate those competing meanings to create something slightly new. So now that I've taken decades of theory that spans continents and condensed it into 4 slides, I'll move on to describe how I've applied some of this work in my recent studies. So this is moving on to the third part of the agenda, offering an example from my health advocacy research. So there are lots of moments when we don't always do what we think we should. So you might be wondering why health advocacy, why is this important? To me, there's no doubt that health advocacy is an important activity that doctors do or don't do. We know that health systems work really well for some people and utterly fail others. This is a famous paper that many of you probably know from the Lancet that argues that glaring inequities exist in access to and quality of care, and that doctors should have something to do about it. Stories like that of Joyce Echaquan bring this argument home in a real way. She died in the healthcare system while facing intense racism from those who were meant to care for her. And I think physicians are clearly more than just biomedical experts producing clinical decisions based on nothing but a bunch of lab results. There's also a very human element in their practice. They're often working with people at their most vulnerable, offering compassion, and sometimes acting as activists when the system fails them. As such, they are powerful gatekeepers of health services. Through their gatekeeping function, they allocate or reallocate resources, including their own time. And the decisions they make about how to do this can either exacerbate disparities or narrow these gaps. But advocacy is hard. It is one of those things that is fraught with all kinds of sociocultural barriers. Even when physicians and trainees feel compelled to advocate, a complex web of sociocultural factors can prevent them from doing so. Systems are often very concrete and resistant to change. As one learner related, it often takes too long or is too inefficient. There's all these hoops and things you have to jump through to get things done. And they are paired with medical cultures that do not always see the role of the physician as aligned with advocacy activities. I think that kind of culture on a team-by-team basis, attending-by-attending basis affects how likely I am to advocate, says another learner. These quotes are drawn from my recent study on health advocacy. It was a large constructivist grounded theory that used interviews to explore factors behind moments when trainees felt able to advocate and other moments when they identified a need to advocate but didn't or weren't able to do so. We explored a variety of different contexts, from first-year medical students to newly graduated doctors across 3 different referral-based and primary care contexts, so pediatric, family, and internal medicine, in both rural and urban settings. Trainees had a variety of different backgrounds and educational experiences prior to entering medical training. I didn't put a ton of information, and I don't have a methodology slide for you here. I'm just giving you the basic context because I think that interests some people more than others. But I'm sure some of you know already, I'm always happy to nerd out about qualitative methods. And one of the things I'm hoping to do now that I'm here at Merit is to build that qualitative research community that others have started. And that seems raring to go. Most of what we saw in the study, another bit of a caveat, which is reflected elsewhere in the advocacy literature, is focused on that advocacy with individual patients. And I think there's a binary there in the literature and in a lot of what we heard from learners between individual advocacy or advocating with one patient and systems advocacy, so advocating for systems change. But I think that at least in our data, this division was a bit artificial and caused problems. In reality, learners and physicians most often engage in systems change advocacy when they see patterns of problems for their individual patients. So this advocacy is both individual and operating at a systems level. It's a bit like a slow escalation of solutions from an individual local solution to a broader system solution. So that's just to say that what you'll see in the presentation are mostly quotes focused on the individual patient, because I think that's the bulk of what we're seeing in practice. But also that it doesn't preclude application to kind of broader system solutions that are part of that kind of larger trajectory of escalation from fix individual problem to fix systems problem. So the product of a constructivist grounded theory study is generally a theory or model. It's a common outcome from sociocultural analyses as well. And from our study, we produced a model to help understand sociocultural factors that influence trainee decisions. And I know, like long methodological discussions, type of model is not everyone's favorite, but I'm presenting it here because it helps me understand and map sociocultural factors that influence trainee decisions. The two larger circles in the model represent the learner's context that they're bringing into the decision-making context with them. So everything that exists outside of that moment of making a decision about advocating. The other represents the larger organizational context. And some aspects of the organizational context may be actively influencing their decision-making in the moment. So that center star represents the decision-making moment, and others may not. And likewise, some of the learner's outside knowledge, skills, and beliefs may influence their decision in the moment, and other aspects may be irrelevant to that decision. For example, a trainee who is father to a neurodiverse child may have extra knowledge, skills, or empathy on which to draw when they encounter patients and families who are in the same boat. And conversely, with other patients or families, that knowledge may not apply as much. In the center, there are 4 sets of factors that we've identified as important to trainees' advocacy decisions. I'll unpack those 4 factors: the patient community, social norms, resources, and social position over the next few slides. There can be sources of friction in each set of factors or things that prevent learners from acting, and also channels or affordances, the things that might help or encourage learners to advocate. Ultimately, the point is to try to create learning environments that support learners in acting to help their patients access better, more equitable care, and to give up on advocacy a little bit less often. I also hope that models like this will help us support medical teachers and learners' resilience when they encounter systems that are challenging to work in, or colleagues who don't seem to care. So the first one I wanted to speak to, and I wanted to emphasize that I'm kind of only unpacking small pieces of each of these sets of factors. But first I wanted to speak to how learners perceive the patient or community that they're working with. And I wanted to emphasize that this is a perception. So these are learners' perspectives on how they see patients rather than the patients themselves. And I think that's important because that perception is not necessarily grounded in reality, but nevertheless affects their decision-making. So by way of a few examples, if a patient seems to be more like them or like the learner, it's often easier for learners to connect and to want to struggle with the system on behalf of their patient. One learner related, as bad as it sounds, when I feel like I'm personally similar to the patient, like I know when I was on obstetrics, when it is a bunch of reproductive aged women, I feel more comfortable being a bit more hands-on with their care. Conversely, if patients are perceived as difficult, it can be a real struggle for learners to want to put in extra effort to help them. Patients I'd call like high maintenance or have a very unrealistic expectation, I would find it harder to advocate for, just because, you know, a personal thing, even though I try to put it away, another learner says. If there's a sense of human connection and the learner has spent time listening to the patient's story, they find it easier to connect and advocate, regardless of how similar they feel at the outset. Learners might forge a connection with patients others perceive as difficult. I found I am much more ready to speak up with patients I feel more comfortable around, like if I've already had a chance to get to know them for a little while, heard their story, had some rapport, and gotten to know them a bit better. And I think these are really human things. It's pretty normal to feel a connection to some people and not others. But I also think that we can find ways to support learners in being intentional about their decisions and finding a connection with patients who are not like them, or finding empathy for patients who others perceive as difficult. These data are also examples of participants' discomfort. And I wanted to flag that because that flags to me as an interesting result that needs some reconciliation. In the 2 quotes I read for you, one of the learners related that it doesn't make you feel good knowing that you're leaving behind some people. Other elements of those quotes are that flagged for me an interesting results are the phrase, it's as bad as it sounds, introducing what they're going to say next, or it's, you know, a personal thing, even though I try to put it away. These expressions of discomfort signal for me a contradiction in values and practices that are worth unpacking. Why are participants uncomfortable with their decision making? And what would it take for them to feel like their decisions align with their knowledge and values? I'm just going to leave that as a question. Secondly, social norms are an important factor that influences health advocacy. We all try to live up to what's expected of us and fit in a social setting. If it seems normal to try to find solutions to non-biomedical problems, then learners find it easier to do that. If they feel like they're swimming upstream, it's much harder. To find out what's normal, they look to their role models and they look to see what's emphasized around them, including in the curriculum. If every conversation focuses on diagnosis and medication and quick turnaround, then it seems abnormal to bring up the patient's inability to cover medication financially, or the fact that they have English as a second language and have trouble communicating with the care need team. And if they can't bring up these issues, then they certainly can't advocate to make change that will ease the patient or family's journey. I'm going to next read two quotes that kind of deal with the issue of role models. The first is, I think, yeah, having role models is also nice, I guess, but it's sort of hard to see in medicine. And the second says, our Indigenous health program curates their preceptors quite carefully. So we always work with people who are quite passionate about advocacy. So we're almost guaranteed that exposure. So having role models who advocate matters, but the lack of role models is also significant in communicating social norms. And when learners do things that are abnormal, it can have social consequences for them. And these social consequences can be hard to take. When a learner relates, you're kind of at their mercy a little bit when you're working directly with them, the preceptor. Because if they don't like you, it's kind of a miserable time. That quote really struck me because it's hard not to fit in. And our data suggests that many learners feel like they're in a position where they can either deal with the social friction and a sense of not belonging in their community, or abandon what they think is right, the right thing to do for their patient. And that's not a good position to be in. And it wasn't just preceptors with whom they were worried about social friction. They were worried about not getting along with doctors, nurses, and other learners. So it wasn't just about career consequences, but a broader desire to fit in. Lots of learners talked about not wanting to be seen as a troublemaker, about trying to be careful about using up their social capital by advocating too hard or too often with preceptors who weren't receptive to that. They also talked about testing the waters to see if advocating for a patient would be acceptable in that context as they move from one social context to another. Third, I'm going to go back a little bit and talk more about the specific tools of the context I sort of mentioned when I was talking about sociocultural theory. So the resources I'm going to talk about next are more like the tools that are available in the context. Some of them are concrete, like the availability of a shelter to accommodate a person experiencing homelessness or the cost of a drug. Other resources are less concrete, but material in the sense that they are relatively durable elements of the environment that don't change that much when people interact with them. The first, we identified 3 of these sort of resources available in advocacy decision-making. The first one is human resources or help. So what help is available? For example, are there social workers at the clinic or other people who can support advocacy? Do physicians and learners know about these people or feel like they can access their help? The second is that access to information. If they see an opportunity for advocacy, how does the learner find the resources or even the phone numbers that they need? Who do they ask, or where do they work, or where do they look? One learner related that they had a working group, a group who gets together every month or 2, and we discuss the development of new clinics that are opening or new resources that we can offer to others, or just a general sense of policy changes coming up. This is a unique example of access to information that acts as a support and facilitates advocacy. It might also be the availability of computers or websites through which to look up available resources, or one learner talked about a resource book that was available at a nurse's station and how they might navigate that to find out what resources were available. And third, I'm going to talk a little bit about available time, but I want to emphasize that time too is a bit of a construct. So available time is relative to what you think is part of your job versus not part of your job. Available time is allocated first to what you think of as part of your job, and then next to things that you think of as above and beyond or extracurricular. So how much time do learners feel like they have in their day to work on these issues? Are they having trouble keeping up, or is there pressure to bill for more patients? How much time do they have to work with a single patient? This is a thing that came up quite often. as a pressure influencing advocacy. One learner relates, with that pressure of having a few more patients, you might not take as much time advocating as you should, or you might not advocate for as many patients. And this fourth component in the model is something that wasn't initially part of the model, but we kept feeling like something was missing from the analysis that we already have. So it had those other three elements. And in constructivist grounded theory, you often kind of go back and forth to the data over and over, and then either generate new analyses or new data to try to make sense of these moments of mismatch where you feel like some data just aren't fitting into what you have. And we realized that where the learner thinks they fit in the organization also matters to their advocacy decisions. We were primarily looking at the differences in affordances based on year of program. So say social position of a first-year medical student is really different than a physician who's just entered practice. They have different kinds of things they're allowed to do and different kinds of power. But I think there are other aspects of social position that also come into play. Like, for example, off-service residents might occupy a different social position regardless of their year of program than others who are on service. And we realized that social position modified other elements of the model. So it changed access to resources, it changed the social norms that govern their participation in the context, and it also governed or changed their interactions with patients. Social position was partly influenced by concrete tools like policies or local practices that delimit what learners could or could not do, but it might also be influenced by social norms. One of the most obvious things about social position, I think, is that it influences the learner's ability to advocate and make changes based on their perceived autonomy. So some of the limits on autonomy were quite concrete. What decision-making power are they granted? For example, medical students likely don't have the power to write a referral or perhaps access a service for their patient, even if they have the knowledge and know what's out there. In this sense, the ability to make a decision and have it actualized is a resource that learners access differently depending on where they were positioned in their training and environment. And if they violate social norms or step outside of their perceived scope, whether the thing that they're trying to do is right or wrong, there can be consequences because of their social position. For example, one learner related that, right now my role is based upon getting through medical school and making sure I pass all the steps. Like if somebody were to come back and say, I totally disagree with what you said or did, it would look really bad for me. So their social position interacts with the norms of the context to impact their agency or ability to speak up on behalf of their patients. And these perceptions of their own autonomy are intertwined with more structural issues or resources in the clinic. Though there might be different practices around time management in different clinics, social position also impacts how much time individuals have to spend with patients, whether they could spend half an hour making phone calls because they're a third-year medical student with 2 patients, or whether they're a fellow with a high patient load and every phone call takes away from the time they have to spend with the next patient. One student related, I think as a med student, you have a unique opportunity to advocate for patients because you don't have all the other responsibilities. Here, social position affords more time for advocacy, but likely less autonomy. And I also wanted to note that these social positions are complicated. So learners in our study also pointed out that their race, the fact that they had an accent or perceived as having an accent, or their gender might change their social position and create affordances or barriers that may not apply to others in their same year of training and in the same context. So from there, we actually started a new study that we're just getting ethics for now, examining these issues and trying to understand how race, gender, and other intersectional identities impact learners' sense of agency during their medical education. Okay, so there's a lot more to unpack. It's a complicated model, particularly around like those outside aspects of learner outside context and organizational context. But I wanted to put it back together again. Because I have this very concrete memory of being in high school biology and studying what nephrons did and how they worked, and breaking my head up from the textbook and thinking, I don't know where a nephron is in the body. I just like don't know where it is at all. So I wanted to try to like bring our heads back up and put the nephrons back in the kidneys, put the kidneys back in the body. So I wanted to come back a bit and highlight how the different elements of the decision-making context might interact. The important thing, I think, is that all of these elements do interact, and they interact in unpredictable ways. There might be affordances in some areas and barriers in others. So the factors don't always impact learners in the same way. That's why it's so complicated. For example, learners might have the background knowledge required to advocate and a lot of empathy for the patient, but not a lot of perceived power in the context. Depending on what else is going on, this learner may or may not advocate. This is why some learners walk away feeling disempowered because they weren't able to help patients even though they saw an urgent need, and why others manage to make change despite seemingly overwhelming obstacles. And a model like this might seem really abstract, but what it can do for me is reframe decision-making context so that we're not trying to make sense of an overwhelming number of factors that have different impacts in different situations. Instead, researchers, teachers, and administrators can look at their context and isolate different pieces to deal with in different moments. But at the same time, remembering to kind of keep our heads out of the biology textbook and situate that and see how our changes interact with other elements of the system. I think that we can also use a model like this to support teacher and learner reflections on their decisions from different perspectives, so that we can apply intention on, for example, how we think about patients' deservingness. So whether we think they're deserving of advocacy based on how we see their care and their responsibility for care, or what kind of social norms circulate, and what norms are worth promoting to build clinical contexts that are supportive of learner agency and advocacy. So that's the end of my presentation, but I'm really interested in kind of what elements of that model or that analysis resonate most for you. So I did create a few questions that could guide our discussion, but I'm also happy to entertain sort of broader questions. So particularly, I was interested in what your experiences are of moments when you don't do what you think you should, elements of the framework that resonate or not. And I'm particularly curious about how you manage and teach trainees to manage conflict between their ideals and the systems that they work in. So thanks so much. I'm looking forward to seeing your faces and hearing your questions.
Hey, thank you so much, Renata. That was really, really excellent. And I'll point to the skill and expertise that's required to simplify such a complex research approach and epistemologies down into just sort of a 40-minute set of slides. And I just want to ask everyone to maybe weigh in a little bit on promiscuity, particularly epistemological promiscuity that was sort of mentioned at the beginning. I had failed to comment on how merit is all about that, so I don't think you're alone. If anyone else wants to self-identify as epistemologically promiscuous on here, then we'll welcome you to the group. I do see that Dr. Daniel Brandt-Vegas has a question, and I assume he's going to speak for himself. So go ahead and take the floor, Daniel.
Sure, thanks. Thanks, Renata, for a really super interesting, provoking, and engaging presentation. Really interested. So what you're describing in terms of those studies, just really, I'm very turned on by, because that's the world I live in, that sort of clinician educator with patients and learners, and the issue of advocacy is something I spend a lot of time thinking about and discussing with learners. So a lot of the elements resonate and are really interesting. I think a few things, or maybe like one main thing that I was thinking about, that I'm not sure, you did mention these concepts, but maybe in different ways. To me, this issue of advocacy really kind of starts the basic root of it in my mind has been autonomy, but patient autonomy. And so trying to determine what the patient's actual kind of wish and values are, and then again, advocating for that to actually take place and to happen. And then power. You mentioned power a few times, but to me, one of the main kind of ways in which power plays a role in advocacy is the power imbalance that's inherent and although variable, but always present in the dynamic of patients in the healthcare system in general and clinicians specifically. And so, you were talking, or it came up in the study that the different levels of power, based on like learners' position in the organization or in the group or in the social environment, kind of affects their ability to advocate. But I wonder if it came out, because to me the crucial part is again the power difference and imbalance between the patient and the learner, the patient and the specialist or clinician, or the patient and whomever else they encounter in the healthcare system. As to me, that's the key part of saying I have all this power that you are lacking in this moment, in this interaction. How can I assign some power to you? Even when you talk about that difficult patient, a lot of times patients that are categorized as difficult are really just trying to claim some power in a powerless situation. And then that just rubs everyone the wrong way, because they're not just accepting of the fact that they're powerless. They're just really trying to reclaim power. So I'm just curious. I'm really excited about your talk in general, but I'm curious about those two elements: autonomy as determining a patient's sort of kind of true wishes and choices, and power, but more from the perspective of the power imbalance that occurs in patients with the healthcare system. Did they come up? Do you have any thoughts on those? Are they somehow accounted for in the interviews or in the structure of the study?
I wish I'd been taking notes while you're talking, because I have so many different things to say. I don't even know where to start. I think one of the main things is that it's perhaps not surprising that when we interviewed learners, they were kind of a bit more interested in their own relative power in the situation and didn't actually talk that much about empowering patients. But certainly one of the interesting things was around racialized trainees. And I think this result has come up elsewhere, that patients have a certain amount of power that changes when the trainee or physician is racialized, right? Like you hear about racist patients and kind of how preceptors are managing that poorly or well. And also the culture of medicine around caring and about kind of like giving up self. So you see patients or racialized trainees actively interacting with patients who are perpetrating racism against them. So I think in that way, the power imbalance or balance between trainees and patients was complicated, because I think we often think about it, medical system has power over patients, and we don't always think about it the other way, probably because it's not as common. And then the other piece was more about sort of trainees really thought about advocacy most often as like kind of more of a savior dynamic, like flapping white coat, I'm going to come down the hallway and kind of save this person from the system. And I think that's something that we need to seriously think about and disrupt when we look at those dynamics. I'm trying to remember what the other half was. One was around power and patient empowerment.
The autonomy, just the other part was the autonomy, the issue of patient autonomy and how to determine, or whether we're determining that, and if that's kind of guiding the advocacy part, I guess. And that has to do with, when we talk about a lot of our actions that are described as advocacy, I oftentimes wonder if we're advocating based on some shared construct that we've heard about or thought about, or are we truly enacting the patient's autonomy? Are we actually advocating to carry out what the patient really wants or needs?
Yeah, agreed. And I was thinking one of my co-authors, co-PIs, Maria Hubinet, has that paper called With, Not For, and sort of advocating for a change in language, but also practice, so that we think more about advocating with patients and kind of raising up their voices as opposed to advocating for patients. And I think one of the parts of the study was to kind of just map out and understand how they think about advocacy, how different trainees think about advocacy. And dominantly, they were advocating for patients. And one of the things that I didn't add to the presentation was this kind of, so when they thought about patients, they thought about kind of like how they relate to the patient. So like, is the patient difficult, or are they similar to me, and how well do I know them, and how much do I care about their story, was one part of it. But the other part was this kind of assessment of need that seems obvious. Of course, we want to advocate for people who need that advocacy more than others, so like people experiencing systems barriers. But the other path is about this like assessment of what the other person needs, and sometimes like more of a discourse of fixing the patient than of advocating with the patient. So I think like especially that one part of the STAR around how they're assessing the patient, like there's a whole other paper that we're trying to develop on that, just because it is so complicated to think about how they're empowering, but mostly not patients, and how like those decisions really do have negative impacts on patients because of that reallocation of resources that can, like if I'm advocating for people like me, white women, reproductive age, like the learner I cite air quoted, then that is, I'm not advocating for people who are not like me, and I'm further exacerbating those disparities. So I think that was definitely something that came out of that piece of it. But like in general, I agree, it all needs a lot more thought, and like thinking about that role has a long way to go.
That's a great idea, though, that rephrasing of advocating with the patient instead of for the patient. I love that.
Well, I'm just going to nudge us along so that we can hear what Teresa has to say. And I'm going to share a couple of links and some of the references people might find useful. One, a publication by Renate on a related topic, and then the Hubanet link that you mentioned. So go ahead, Teresa.
Thanks, Sandra.
Honestly, I'm very fascinated by your work as well. I do think that power plays such a great role in all the systems that we have, and figuring out how we manage conflict within kind of like your personal values and the system's values. I think there's definitely some really cool intersections around, especially even some of the more hot button topics like, you know, abortion or other things that where there's like actual institutional, you know, barriers to someone having access to birth control at a certain hospital in town that I will not point out, but you know, because of the funding pathway of that hospital, right? And so I think that we're like this area is really exciting. I would say that one of the things I'll point out is the racialized experience may need to kind of be filtered with a layer of complexity when it comes to different racialized groups and their experience with healthcare, their presence in healthcare sectors, underrepresentation, overrepresentation in certain domains and areas. I guess as an Asian woman, I will point out that there has historically been pointed out that there's a bit of a leadership ceiling for Asian individuals. And you think about how overrepresented certain kinds of Asian individuals are in medical school classes, and yet there is one decanal position, like one dean across all of the deans right now that is you know, a male Asian surgeon, right? And so it's interesting to think about some of these things and how they play out in different ways. And I was just wondering how, with that amount of complexity, as a fellow scientist, I'm wondering, how do you sample for sufficiency when there's so much nuance and something so charged and so nuanced?
Yeah, so that's that new study I mentioned that's trying to look at how intersectional identities impact agency when trainees experience racism. And I think like you can't ever have a totalizing thing. Like the same with this model, I can't say like this thing happening with the resources is going to impact trainees in this way and they won't advocate anymore, because it interacts with so many other things in the system. But we are trying to map how intersectional identities are working, because I think right now in medical education, we don't have very nuanced tools to support racialized learners, and we think that instituting one tool or one reporting program will help all racialized learners deal with racism equally. And it's just not true. And I think like following Black Lives Matter and the shooting, I think it's San Francisco, was it? That kind of like created this whole movement around talking more about sort of Asian stereotypes and racism against Asian people. I think there's, as a result, a lot more writing about kind of how model minority stereotypes are impacting people negatively, rather than kind of writing off those overrepresented learners and saying, hey, they're not having a problem in the same way that underrepresented minorities are. So I think there's a lot more conversation going on, and I think like using intersectionality theory as a lens and then using constructivist grounded theory to kind of like look for what's important in terms of intersectional identity and kind of like poke at those constructs are both really helpful. But I'll start talking now because I see that I'm already over.
Yeah, clearly this is a complex topic. We could spend hours and hours just debating or looking at all the angles on health advocacy. So I want to thank our audience again for tuning in. We will end the recording fairly soon. If I can add one comment, which is my particular training comes from a very post-positivist world, and I feel like there's been some strong influence of that world on how we do our research. And I'd seen some sort of comments earlier about the complexity of research methods and how we explore these education problems that are around us. And I think if we just are happy to accept, what a post-positivist epistemology would have us do, which is just focus on the context-free situations that we can control in experiments, then we're really going to be missing out on lots of great opportunities to really understand problems and make some strong impact for our trainees and for our patients. So I'm particularly happy that Renate is joined Myriad and that we have access to some expertise in how to unpack the complexity behind these education problems.